Hello, everybody. Welcome to this wonderful lecture for today. So let me make sure everything's going smoothly. I am recording good, perfectly. I'm recording, I'm doing everything. All right, so today we're going to talk about different ways to build knowledge. And I think this is an important topic given how little people know about research and all the assumptions people make, especially in this time where there's a downplaying of science. Indeed, it's important to note that there was an executive order signed by President Trump that well, I don't know if it's well, at least right now it's cutting funding, all federal funding, and this affects people who do research. And this is not a good thing because a lot of people's lives depend on research. I mean, people actually work as researchers, and most of the research done is very, very beneficial to everybody. So there's not a misunderstanding of science. So having a session like this helps you get an idea of the scientific process, at least in a small part. This isn't a research methods course, but in a small part, it gives you an idea of how we go about formulating ideas and a little bit about history. Science is not a quick fix, and I think people get misconceptions that solutions are rapid. They're not. It takes forever, long, long time. So let's get started in terms of building knowledge. Really, there are two ways to build knowledge. One is through deductive reasoning, and the other is inductive reasoning. If you look at this figure kind of explains the two types. With inductive reasoning, we start by making observations, and our observations are used to formulate hypotheses. Once we formulate hypotheses and conduct research to hopefully validate our hypotheses or at least to get some support for them, we start formulating theories, right? And the theories are kind of a way of explaining the world around us and phenomena, relations among different variables. Deductive reasoning, on the other hand, starts with theory and works its way down into practice. So theories generate hypotheses, and then that informs practice. So some of the practices that you see conducted in, say, psychology or in public health or in other areas were based on theory, right? So a good there's nothing more practical as a good theory, as a saying goes. I know it's really hard to figure out who to attribute that saying to, and I know people may think that they know who to whom to attribute it, but it doesn't. But we don't know. But I love that saying because theories, even though they seem very very vague, nebulous, they're actually very practical because they help us understand how variables are related. So let's dig a little bit deeper into how we do inductive reasoning. So again, we start building our theory from observation, and this is a very multi-step process. We need start by identifying a problem behavior, and we identify these behaviors in many different ways. Sometimes it's just by observation, and other time it's through publicly available sources. Like for instance, a problem behavior could be something like binge drinking, and health out could be something like gastroenteritis or some environmental condition like standing water, toxic waste, neighborhood crime. These are all conditions that we can observe, right? So we identify the problem behavior. We identify sources associated or conditions associated with the problem. And sometimes that you can do that through observation or you can do that through using publicly available sources. So let's look at the publicly available sources that we can use. One of them is MMWR or Morbidity Mortality Weekly Report. I think I already have this downloaded here for your viewing pleasure. Here it is. So here's an issue of Morbidity, Mortality Weekly Report, MMWR. And this is an interesting one, looking at associations between waterborne disease outbreaks associated with splash pads. Well, I didn't know what a splash pad was until I read this, but apparently it's one of these areas where kids can play in public and there's water everywhere. That's it. So it's a splash pad. And so looking through data like this that are publicly available, or in this case, these are studies that are done by by researchers who work at the CDC, you can find some interesting associations. So, for instance, let's see what they found here. During 1997 and 2022, public health officials from 23 states and Puerto Rico reported 60 waterborne disease outbreaks associated with splash pads. These reported outbreaks resulted in 10,611 cases, 152 hospitalizations, 99 emergency department visits, and thankfully no reported deaths. Most of them were caused by cryptosporidium. Seems like this is like a big pathogen candidate, this bacterium for waterborne diseases. So it's interesting, right? So maybe you might not have thought of that before, but here's something that just by looking through publicly available literature, again, going through MMWR, can find something interesting. You may not be interested in that one. You may be interested in like gaps in mental health seeking among healthcare providers during COVID-19 pandemic, and there's so many other things, right? You can learn just by reading this. Of course, you can also look at just plain publicly available data, right? These other surveillance summaries. Let's see. We just looked at that one. Abortion surveillance, laboratory confirmed influenza associated hospitalizations among children and adults. There's a lot of stuff here, right? That can help you generate your hypotheses and lead to research. So that's definitely one important source of observation, but I'm observing data that are already available. I can also read the literature and looking when I talk about the literature, some you may consider what I just looked at, the literature, that's fine. But beyond CDC sources, we can also look at research sources through, say, Google Scholar. If you're not familiar with Google Scholar, you should be. That's where you can find much research. So here's one that's interesting. E-cigarette use and depression among American Indian adults who smoke. So again, you get ideas of what things are related, right? Like here, you're looking at depression and smoking, and in a specific population, right? So interesting stuff, right? Interesting stuff. So one source of observation is to go directly to the literature, and that seems to be the preferred source in the academic realm. I don't think it's always the best source because we don't get every observation there. We only get ones that are vetted and pass this test to get published in a peer-reviewed article. And you think, well, of course, isn't that what we want? Absolutely, that's preferred. However, some of the articles that aren't published are also good too. Like, for instance, if one has a negative result where they don't find anything statistically significant, sometimes those articles don't get published. So there's a bias toward against negative results. So we're only seeing a snapshot of what actually the findings actually are from scientists out there. But that's definitely a good source to start with. Direct observation means just using your own senses. To have credibility, you will need to find observations in the data and publish research, right? Like that's what I mentioned. However, this is another place to start your journey. I have made plenty of observations, but when you mix your observations that you directly make with observations you get from reading the literature, you can actually make some pretty darn good observations. So a question to you all is, what observations have you made that intrigue you? What factors do you believe, based on your observations, are related to these issues? I want you to write them down. And again, when we look at the literature, we can find factors that are related to whatever we observe of interest. Like I may observe that I tend to drive a lot, so I always think about aggressive driving, and I always formulate hypotheses about why people do crazy things. The other day I was driving and there was like a small gap between me, my car in one lane, and the car in front of me, but a one lane over. It was a very, very small gap, just enough to fit a car, and boom, this car went right into it. It's just, it's interesting, right? I mean, what would make somebody do that? So I'm always thinking that it's that these people are antsy, and I start thinking about accidents, and I always think that accidents are caused by people who are really selfish and only think about their own needs. So that I'm formulating hypotheses as I'm going along and just driving around. Similarly, if you're walking and somebody almost hits you, I was just walking to get my coffee this morning, and as I was walking, I pressed the button for the walk whatever the walk signal is at the stop light, the crosswalk, and I started crossing after it started flashing walk. This car just barely passes by me, screeching by. It could have hit me. So, it's just, it's, what would cause somebody to do something like that? Is it carelessness? Is it selfishness? I always tend to think it's selfishness. People want to get to where they want to go and they're not concerned about others. All right, so once we have our observations and we see potentially related factors, right? Or we believe there are certain factors related to whatever we're observing, we propose an explanation. So this is our model to explain the relation among phenomena, right? So it's the building blocks for a theory. So here are questions to ask. Is or are the proposed relations among the variables direct or indirect? So direct means there's a direct effect from the putative, the supposed cause to an outcome of interest. A proposal that the cause directly affects the outcome, and here's some examples, are a blow to the head causes a concussion, right? That's a direct effect. You get blow to the head, you get concussion. So here it is right here. Predictor and outcome. Blow to the head, outcomes concussion. A shooting causes a death. That's a direct effect. There's nothing mediating that relation. Not wearing a seatbelt causes personal harm in an accident. That's one way we can hypothesize an effect. We can also hypothesize an indirect effect where you have this, and again, I always say putative because we don't know if it's real until we test it, right? If this is the real cause, right? The predictor causes that outcome. We we say it's a cause, and really, if you know anything about research, the only way to determine cause is through a randomized trial, right? A randomized experiment, right? So, or randomized clinical trial, if you want to call it that. But so I just call it a predictor, a putative. It's supposed. We don't know yet. Predictor and the outcome. In a mediation world, we have some mediator, what we call a third variable, through which the effect of the predictor on the outcome is proposed to be channeled, right? So this predictor variable you think has a direct effect. However, its effect may be channeled through the mediator here, right? We call this actually a third variable. This is generally what is known as a confounding variable. A confounding variable is a variable that's related to the predictor and the outcome, and it can affect the way the two variables are related. In this case, we're proposing that it actually does have an effect. And you see these little arrowheads here pointing the direction of the effect. Some examples would be something like vectors. As you know, vectors are arthropods. Like a mosquito mediates the relation between a reservoir and a host, right? Vaping mediates the relation between pure vaping and vaping-related lung disease, right? So those are mediators. However, as we're discussing what our model is, we may also see that there are moderator variables. So moderator variables affect affect the relate with an A, not E, affect, right? We call them effect moderators, but they affect the relation between the predictor and the outcome such that you have different effects based on levels of this effect moderator. A lot of effects and affects here, right? So in an example here, we may have something like the effect of one's weight on depression, and that may differ for males and females. Like for Males' weight might reduce the likelihood of a depression. For females, it may increase the likelihood of depression, right? Another example would be something like SES, socioeconomic status, moderating the effect of a virus on death. And we've seen this in the past where certain viruses were more deadly during periods of starvation and stress. So there's greater stressors on people who have low income. So that would be an effect moderator. One can also propose moderated mediation. Do I have a picture of that? I think, yeah, well, this is actually moderated mediation, right? So you have mediation and different mediated effects based on the effect moderator. So it's pretty cool, huh? So you have to think about all these things when you're doing your stuff. Next question, next step, write your research question. A research question is a question. You have to be specific in terms of what the putative cause and effect variables are, and any mediator and moderator. When I mean moderators, when I mean be specific, just tell me how you're measuring something, right? It has to be asked in a very, very specific manner. So let's see what I have here. Oh, this is for you to do, but I might think of something like, I don't know, what my question might be, what's the effect of vaping on depression, right? To be specific, I'd say, what's the effect of vaping greater than or equal to 1 time per day on depression as measured by the Center of Epidemiological Studies Depression Inventory, the CESD. So I'm being really specific here in my question because I'm making it so that it'd be really easy to write hypotheses from that. So here's a question for you. There has recently been strong concern about police violence, excessive and unjustified force based on one's race. What is a research question you could ask related to this issue? So proposing a research hypothesis. A hypothesis is a testable statement. We really want to write testable statements. Generally, we write them in a way that portrays what we're interested in finding, right? Like we'll say here, well, actually, that's just something, a question for you all, but I would write it in a way that can be either verified or negated. So I could say, for instance, oh, what was I talking about a moment ago? How about something about vaccine hesitation? Is there an increase? My research question could be something like, oh, I did the vaping. No, I did vaping and depression. My hypothesis could be that vaping greater than or equal 1 time per day is associated with an increased level of depression in comparison to individuals who do not vape at all. So I can compare depression between the two, right? So that's my research hypothesis. So that's what I'd like to show support for. I'd like to be able to show that individuals who vape at least 1 time per day are more likely to have higher depression scores than, or depressive symptom scores than individuals who don't vape. So, what is a research question? And all these ones marked in yellow are ones that you have to answer and then post on Canvas. What is a research hypothesis you could formulate related to the issue of excessive force in policing, particularly as it is related to ethnic minorities? Next step is to seek data to test our hypotheses. If available, it's really great to conduct a secondary data analysis. In public health, there are a lot of secondary data available. Thankfully, there are organizations like the CDC collect data and make these data available to us for use. A good source is the BRFSS, or the Behavioral Risk Factor Surveillance System. See if I can go to the BRFSS. Here it is. And you can have like all kinds of good data. Like here's the 2023 data set, and there's so many ways to do this. You have the questionnaires so that you can actually see what the questions were. You have the data, the data tools for analysis. You actually have the data itself where you can download it. Like I did a study with a student at a student recently where we looked at how depression is related to colorectal cancer screening or maintaining a colorectal cancer screening regimen as recommended, the recommended regimen. And that was something that we used the BRFSS for. And this data set's huge. So there's like, I think because we restricted our sample to people who are 50 and above. Most cancer screenings, colorectal cancer screening is recommended to start at 45. So we started at 50 to give a little lag to people start getting their regular screening. Still had like over, I think like 200 and something thousand people. That's a pretty large data set, giving us a lot of power to test our hypothesis. It's great. And there's also the YRBSS, the Youth Risk Behavior Surveillance System. But these data sets are available, but again, you have limitations because they aren't yours. You didn't create the data set, so you're limited to whatever they measured, right? Like maybe we wanted to measure something about psychological factors. We did depression, but maybe we wanted other factors, but they weren't available because they weren't asked. If you don't have what you need, you just propose your own study, right? So you can propose an observational study or an experimental study. Observational studies look at relations among variables, like correlations and regression. And there's tons of different statistical methods you can use. But in observational studies, you're basically using data, but you're not conducting an experiment. So experiments are considered better in terms of determining cause and effect than correlational studies. However, correlational studies are pretty good. And again, it depends on what you're doing, because some things you just can't do experiments with. They're impossible. Experimental studies have control groups, and if they're done correctly, well, not all of them have control groups, but they should have control groups. Really strong experimental designs have control groups and random assignment to the different levels of the experimental variable. Like say if I'm looking at the effect of uh, exposure to vaping on vaping itself. I can have people who are exposed. I can randomly assign individuals to exposure and non-exposure and see what the outcome is. Experimental studies are hard to conduct because of ethics, research ethics. We can't do everything we'd like to do. People have in the past, and then, of course they've committed crimes doing that, right? You can't just because you like science, you can't propose a study and just do it. Okay, so but anyway, if we're conducting a study, whether it's correlation or observational, we still have to identify our sample. Our samples are identified to make inferences about the population. If it's ideal to have a random sample from the population where each individual has an equal likelihood of being selected into the sample, but that's not always possible, but that's the ideal. We identify our sample and I should say, and our sample size too. Maybe I mentioned that later. No, yeah, no, I don't. So, and our sample size, that's something that you have to know too, because you need sample. So this is beyond the scope of this lecture, but you really need to know what the sample size is to ensure you have power, the ability to reject a false null hypothesis, formulate your procedure for collecting data, secure support, funding for your study. I just mentioned earlier that there's this like temporary, hopefully temporary shutting down of funding. We need funding to conduct studies. You can't Studies aren't free. Conducting studies isn't something for free. People want to get paid for their time, and we want participants. So generally, we add some kind of an incentive to do a study, but we have to be careful how much of an incentive we add, because if it's too high, we can get people to do anything, and our incentives become coercive, right? So we have to have the right balance, and to determine the balance, we rely on the Institutional Review Board or the IRB. IRBs have to validate our studies before we're allowed to proceed. Their goal is to protect participants from harm. One question asked is, do the benefits of the study to the population as a whole outweigh the risks to the participants? So I could come up with a new treatment for, say, something like psoriasis, but this treatment is extremely dangerous to the participants. Does it benefit society as a whole? And does that benefit outweigh the risk to the participants? May or may not, right? If in cases like COVID, we kind of like had a quicken IRB because we thought this was a global emergency and we were worried, right? So the globe and all the researchers went into high drive to figure out what to do. So probably taking more risks than you normally would because this was perceived as a global emergency and it did kill a lot of people. So there was this idea we have to get this done quickly. But the IRB is still there and it's still functioning. So they won't let you just do anything. So you have to make sure that, again, the benefits to the population outweigh the risk to the participant. And in cases of emergency, sometimes you can go ahead with a study even if the risk of the participants are high, so long as the benefits to the population, and I repeat that over and over again because it's important, benefits to the participant cannot outweigh the benefits to the population as a whole. We have to look at the population, like when we're doing something, we're trying to make inferences about the population or generalize to the population. Now, in terms of just some of my direct experiences with observations, I had a study I did recently that looked at the effects of the subjective importance of smoking on ability to quit cigarette smoking. Now, cigarette smoking still remains a leading cause of death and disease in the United States. So it's a behavioral cause, right? People do something and it causes death, right? So um, and by observing cigarette smokers, I realize that these individuals are completely enmeshed in a relationship with their cigarette that doesn't make sense to a non-smoker. So I created a study um, and a survey called the Subjective Importance of Smoking, or the SIMS, and I used that to assess, just to kind of get an idea to assess how important cigarettes are to individuals. So I've done several analysis with it, and in one of my publications, I talk about this. So you can link to that publication here. And then I also wrote a story about what it's like to let me go back into what it's like to create a measure, right? So here's the SIMS if you're interested under ResearchGate, my name, right? And then the article looking at the navigating the many hurdles of creating a self-report measure. This is a good text that shows you how difficult it is to create a measure, right? It's not an easy thing to do, and I wouldn't recommend it to those who don't have a lot of time on their hands. Okay, let's talk a little bit about the history of public health and how and the role of observation in the history. I'll give you a couple of historical examples. We'll start with John Snow and cholera. So these links here are to videos. This is a TED Talk on John Snow. So Vibrio cholera is the pathogen that causes cholera. So this terrible disease that obviously involves diarrhea and, terrible illness. It's a waterborne disease. Originally, it was believed that it was caused by this fog. What they call this, the miasma theory, or bad air, because it smelled so bad in cities, especially like in London, like the first major metropolis. You had it's horrible smell because people would throw their waste in their basements and stuff. So it just was really disgusting. So people believe that this bad air was the cause of disease. Interesting though, one of the innovations of John Snow was the use of early GIS, geographic information systems, through mapping. And see, here's a example of, I think, oh, here it is, an example of his map. I looked up a nice picture of his map where he showed how many deaths there were in homes near this one pump on Broad Street. There was this water pump that was supposedly had the best tasting water in London. So people were dumping their waste in these cesspools near this pump. So their waste was interacting with the water people were drinking. So his observation here and this early map showed that the closer you were to this pump, the more deaths you had. So that's how he actually was able to link the pump to those deaths. It's interesting though that we use GIS now for a lot of the different things, and it's very useful because these pictures are so, I don't know, they're so powerful versus if I give you a table of figures. Tables, it's just a table, but this one is actually not a table. It's beautiful. It shows you like just shows you visually what's going on. And that's what's beautiful about these maps. Anyway, you should watch that. He also conducted this experiment known as the Grand Experiment. So it was based on water distribution in two parts of London. There were two different water companies. The Lambeth Waterworks Company was further upriver and less contaminated, better water source. Individuals who were supplied by this company had 37 deaths per 10,000 residents. And again, in public health, we always talk about things per some number that makes sense. Like you're talking about a big city, you want to see how many deaths per 10,000. You're not talking about per 100%, right? So it's better to do it per 10,000. In COVID, we did per 1 million or per 100,000. The Southwark and Vauxhall water companies that were closer to the city and more likely to be contaminated, we had 315 deaths per 10,000. So a big difference there. So this was considered to be proof that there was a link between water and cholera. However, later on, we've learned that the study sucked. I'm sorry to use it that way. Methods were just not very good. The data were not reliable, and it's considered a bad study. However, he was still right. So that kind of worked out for his advantage, but not a very well done study. Another famous history where observations were used. So again, I was talking about how observations were used here. That map that I showed you is an example of observations. Another famous story, although this is not the only time this happened and the only part of the world in which this happened, people have been fighting smallpox for a long time. And Edward Jenner is credited with creating the vaccine for smallpox. But people have been battling smallpox for a long time, and or they've been using methods like variolation in order to inoculate individuals against smallpox. So initially, variolation was inoculating. You get a little cut, and then you stick some of the live virus in an individual from somebody who's infected with smallpox. So that's inoculation. Of course, that could be dangerous too, because one could develop smallpox from it. But the idea here was to create an immune response so that one would be immune to this virus. The After a while, Edward Jenner and others too, so let me just make it clear, others around the world noticed that milkmaids who got milk from cows, if they got cowpox, they were less likely to contract smallpox. So what Edward Jenner did, he found this milkmaid, Sarah and Elms, and he extracted some matter from a cowpox legion and inoculated James Phipps with it, right? And that's was the first supposed vaccination. Interesting, just for your information, vaccination comes from vaca, cow, right? Because cowpox vaccination, right? Isn't that cool? I love these little things. Now, this study would never pass an IRB as it was designed. You can't just take some child and just say, well, I'm going to vaccinate him and let's see what happens. because he developed cowpox. And then not only that, but Edward Jenner inoculated him with smallpox afterwards to test to see if this worked. So, that would never fly. But again, as I mentioned before, the global impact of smallpox was huge. So one would probably argue that the effects on an individual warrant the risks to the individual are warranted based on the global impact. But I'm sure we'd have to do a better study than that by now. Now, a third example is Ignaz Semmelweis and childbed fever. So childbed fever, also known as puerperal fever, was a streptococcal infection that affected women who are delivering who are in delivery, right, delivering their newborn. Um, there were two clinics in Vienna, Austria. So Ignaz Semmelweis was a physician. He's Hungarian, but he was practicing in Vienna, Austria. And babies or infants were delivered in two clinics, the first clinic and the second clinic. The first clinic was run by medical students, which you think would be the good one. And the midwives in training were running the second clinic. Well, the problem was the deaths were a lot higher in the first clinic than in the second clinic, to the point where people did not want to go to the first clinic, right? It's reported that women would actually deliver their their newborn in streets to avoid going to the first clinic. And I think that, as far as I remember, there was a system based on the calendar of when people would go to the first versus the second clinic, taken to the first versus the second clinic. So if you were in that wrong group that was going to the first clinic, it was very scary. The reason for the well, what Semmelweis observed was that the medical students in the first clinic would go directly from doing autopsies on women who died from childbed fever to the delivery room, right? That's what he noticed without any preparation. So he instituted a chlorinated lime hand washing regimen. And based on this observation and this hypothesis, his hypothesis was that chlorinated lime or washing hands with chlorinated lime would reduce the number of deaths from childbed fever. Death rate reduced by 90% after the hand washing regimen was introduced. There was resistance to his ideas, and this is kind of scary and sad. And people resisted the idea because what happened was, by saying that these medical students in the first clinic were causing these deaths, it kind of makes them liable. And nobody wants to think that, I'm a good person. I'm, supposedly doing no harm. That's what the Hippocratic Oath is to patients. I'm doing no harm. I'm trying to help people, yet you're killing people. So there was a resistance to the idea. And it's really sad. That's when we do things in public health, it's always for the good of people, but it always comes with some risk, because you're, in a sense, not purposefully, but you're like basically insulting somebody by saying, hey, you're not washing your hands, you're killing people. And a lot of people have difficulty taking blame instead of admitting, well, we were wrong. Let's reduce this risk right now. It's kind of sad. Here's two more questions for you to answer. What, or a couple of little things for you to do, including a question. What's the best way to attack resistance to a public health initiative in our current political climate? And there's plenty of issues out there. And then your observation, regarding your observations, I want you to write your observation, because I asked you earlier about observations. Write your observation, write a research question, and a hypothesis, or you can do more than one hypothesis if you like. That, my friends, is all I have for today. Thank you very much, and have a wonderful, wonderful day.